All right, well, it appears that the powers that be have decided that I was not meant to teach you guys metabolism and regulatory disorders in person. So, because of Mother Nature's decision, I am going to put this lecture up for you guys as well. If you have any questions, anything you guys are unsure of, please shoot me an email and I'll help try to clarify things for you. Or we could always get together as a large study group if that works as well. Just let me know. All right, so here are all of the readings we're going to do. Some of this stuff is coming, well, most of it is coming from your Med-Surg book, and then some of it is coming from your Fundamentals book. My lecture is primarily coming from the Med-Surg book, so I would say use the Fundamentals book as a resource if you guys are rusty on some of the different skills. I already posted this in Patho, but just a reminder, the metabolism regulatory system is connected and related to all of the other concepts in the body. All right, so we are going to start with diabetes this time, right? And just as a quick reminder, diabetes is that group of metabolic diseases characterized by increased levels of glucose in the blood, which is hyperglycemia. And it results from either defects in insulin secretion, insulin action, or both. Right? And there's those 4 types of diabetes: type 1, type 2, gestational, and the others. So diabetes associated with other conditions or syndromes. And then there's prediabetes. So I do highly encourage you guys to look at table 51.1 in your book. It is a really good resource for the different types of diabetes and the clinical implications for each of those. And just a quick FYI, once I delved into the chronic world, I found that the Med-Surg book does a great job at explaining the patho of the diseases too. So if you're having a little bit of a hard time understanding the patho and reading the patho book, definitely take a peek at the patho sections of the chronic book. All right, so the reason we're talking about this so much is nurses are going to care for patients with diabetes in all settings. I mean, 1 in every 3 adults in the US could have diabetes by 2050. That is their projection. So regardless of whether you work in peds, mother-baby, any of the OB realms, adult, mental health, you name it, you are going to encounter a client with diabetes. Okay, so it's really important to understand not only the patho of the disease, but the prevention, the diagnosis, and the treatment of the disease, because that's going to be the nursing care. Some potential consequences of diabetes: non-traumatic amputations. In the US, diabetes is the leading cause of non-traumatic amputations. Blindness in working age adults. End-stage kidney disease, death. So diabetes is the leading cause of death from a disease, primarily because it comes with that high rate of cardiovascular disease. Hospital rates for people with diabetes are 2.4 times greater for adults and 5.3 times greater for children than the general public. And the economic cost, I mean, it continues to increase because of the increasing healthcare costs, the increasing aging population, and the increasing amount of diabetics. And these are just some of the more major consequences, but diabetes can impact people's lives on a whole range of things. So I know I mentioned some of the risk factors for diabetes in patho, but the reason I'm going to bring them up again here is because nurses are going to play a really key role in helping people modify these risk factors. So hopefully either preventing them from developing diabetes, or if they do develop diabetes, keeping a good control and preventing some of those major complications. So the risk factors is going to be a family history of diabetes, obesity. So you have a lot higher risk if you are about 20% or more over your desired body weight or body mass index of 30 or more. Race and ethnicity, so African American, Hispanic American, Native American, Asian American, and Pacific Islanders all have a higher rate of diabetes, with Native Americans being the highest. The age, so if you're 45 or older, you're at higher risk. If you have previously identified impaired fasting glucose or impaired glucose tolerance, so prediabetes, that kind of thing. Hypertension has been linked to increasing your risk of diabetes, as well as having high density lipoprotein and cholesterol levels of less than 35, and then triglyceride levels more than 250. And then a history of gestational diabetes or delivering that baby over 9 pounds. So there are some, when you looked at those, I'll go back to it, some of these risk factors are modifiable. Right? Unfortunately, you can't change your genetics, you can't change your family, those kind of things, but some of the others are modifiable. So when we're talking about teaching for our patients or clients or whatever you want to call them, these are the things we're going to work on. So prevention really is the key. It is so much easier to prevent someone from having diabetes than it is to start treating it once they develop it. Well, mind you, I wouldn't say it's easier to prevent it. Prevention is easier than getting it. Let me say it that way. So, looking again at the modifiable risk factors, lifestyle changes, right? So some people think that, if I just make some dietary changes, or, if I just increase some activity, it'll help. But they really need the combination of both. So, healthy diet with that activity increase. Studies have even found that a modest weight loss of 5 to 7% and then regular exercise of 30 minutes a day, 5 times a week, significantly lowers the risk of developing diabetes for people who are obese. It lowers it by 58%. So when you're talking to your clients, or again, whatever you want to call them, it's not a matter of telling them, hey, you need to drop 100 pounds or you need to be this amount of weight. It's about, hey, if we can just get your weight down by 5 to 7%, right? Smaller changes. It makes it sound more realistic and more likely to happen. And it does, again, 58% chance of decreasing, or 58% decrease in developing diabetes, sorry. So it does make a difference. It doesn't have to be anything completely drastic or major. So now we're going to talk about assessment, right? And there's 3 pieces to the assessment. There's the history, the physical, and then the different diagnostic tests. And one of the issues with diabetes is a lot of times early detection isn't done, and that's simply because really the symptoms are absent or not really specific. So a lot of times when someone does come in, they discover they have diabetes just from the routine lab testing, or because their diabetes has gotten out of control with things like ketoacidosis and stuff like that. So looking at the history, you don't want just a medical history, you want to look at a family history, a smoking history, social history. So what are those things that put someone at higher risk? So things like smoking, alcohol, their occupation. You want to find out about their diet. A great way of doing that is having them fill out a 24 or 48-hour diet log where they list everything they've ate. And then coping strategies. Okay? It also includes medications, both supplements and prescribed. And sometimes, there are other causes of hyperglycemia. So maybe their blood sugar's raised because they're on steroids. right? And if you didn't know that and you checked the blood glucose, you would start freaking out thinking they were diabetic when really it's because they're on a steroid pack. And then you also want to look at what symptoms, what is presenting, what brought them in, right? What's going on? Right? Are they losing weight? Are they gaining weight? Do they feel tired? Are they jittery, right? What are their symptoms? The second part is the physical exam. So looking at the appearance of the person in general, their skin, their hair, their nails, their reflexes, their musculoskeletal system, basically all of the body system, along with height, weight, and then the lifespan considerations. So if it's a child, how are they on the growth chart? If they're elderly, has there been any changes in appetite or activity? Okay. And then looking at diagnostic tests, you're going to want to look at that fasting blood glucose, a lipid profile, basic metabolic panel, the hemoglobin A1C, and then looking at metabolic disorders in general, you're also going to want to do a thyroid study. All right, so this next slide comes from the chart in your book, chart 51.3, and this is just a little more detailed on some of the specifics of assessing the patient who already has diabetes. Right, so looking at, what you're going to ask about the history, so the symptoms relating to diabetes. Do they have symptoms of hypo or hyperglycemia? These kind of things. So I highly recommend you read this and you use this as a reference on what to do when you're tailoring an assessment to a diabetic client. So with diabetes treatment, the main goal is going to be to normalize insulin activity and blood glucose levels to reduce the development of complications. The therapeutic goal is to achieve normal blood glucose levels without hypoglycemia, while again maintaining that high quality of life. So one of the first things in managing diabetes is going to be nutritional therapy. Right? And there's a lot of different, I could give you a 3-hour lecture just on nutrition and nutritional therapy, especially pertaining to diabetes, but we're not going to get into that. So just the basic gist of it, right? They need good nutrition. They need meal planning, weight control, and then remember, you can't just have nutrition alone. It has to be accompanied by that increased activity. So a lot of people recommend that diabetics follow a diet using an exchange list. Right? Way back when the dinosaurs walked the earth and I was in nursing school, they had this set diabetic diet, right? Don't give diabetics bananas, don't give them this, don't give them that. Now they don't really do that. Now in general, it's just everything in moderation, just like any diet, right? Everything in moderation and trying to get a lot more of the healthy stuff than the unhealthy stuff. But this exchange diet has actually become pretty popular. So basically, and on the table, it gives you a sample menu. Basically, there are 6 main exchange lists. So there's your bread or starch, there's your meat, your vegetable, your fruit, your dairy, and your fat. So when they go to plan the meal, the dietitian or whoever gives them a certain amount of exchanges a day. Right? So they need to have 6 exchanges of fruit. Or sorry, that would be too much. 6 exchanges of vegetable, 1 or 2 exchanges of fruit, right? Maybe they tell them you have to have 3 meat exchanges per meal, right? And then this just gives you an example of what it looks like. So your 2 starch exchanges are 2 slices of bread. And then, of course, you'd want to tell them that it needs to be a whole grain bread, not a refined carb bread. The 3 meats is going to be 2 ounces of turkey and 1 ounce of low-fat cheese. So basically 1 ounce of a meat group counts as an exchange. And then there's the vegetable. For raw vegetables, 1 exchange is a cup of veggies, and for cooked, it's a half a cup. And then you can have 1 fat, and look how minimal that fat is, right? So it's 1 teaspoon of mayonnaise. If you want to go with light mayonnaise, you can use a tablespoon. Okay. One fruit, so a medium apple. And then there's the free items, so things like your mustard and your pickles and your unsweetened and sugar-free things. These are considered free because they don't really have any calories or fats or carbs or anything like that. So I know my older daughter, when she became diabetic, and this was when she was in, I want to say, the 9th or 10th grade, she did have to meet with a nutritionist, and they didn't so much do the exchange for her, but they did carb counting. So that's another option too. So telling them you're allowed to have 60 carbs for each meal, right? So that's one way she went about doing that. But they are, again, like I said, they're using the exchange diet a lot. It's one of the diets they recommend people who are considering bariatric surgery or medical weight loss and those kind of things. They have them fill out that. Another option is going to be teaching them to, and that's not an option, everybody should know how to do this, teaching someone to read nutrition labels. And I know as nursing students, this sounds kind of common sense, but for the average person, it really isn't. Heck, for the average person, some people don't even know the food groups and what belongs to what, right? So teaching them to read the nutrition labels, looking out for how much carb and fat and calories and that kind of thing, and helping them to make or help them learn how to make healthy food choices. And then, of course, you've got your My Plate, right? Gone are the days of the food pyramid. So we've got My Plate, and that's really good online. They've got the meal tracker and the calorie counting and all these lovely things as well. There are tons and tons of apps out there now, too, that track everything. I mean, there's even apps that remind you to drink water and keep track of how much fluids you're taking in. So this next slide is just a really good resource on some general considerations for exercise in people with diabetes. So as the nurse, you should be instructing people to exercise 3 times a week at least, with no more than 2 consecutive days without exercise. And then they want to also add performing resistance training twice a week if you have type 2 diabetes. They should exercise at the same time of the day, usually when blood glucose levels are at their peak, and then for the same duration each session, so 45 minutes each time, for example, or 30 minutes each time. They need to use proper footwear and protective equipment. You want to teach them to avoid trauma to the lower extremities, especially if they're experiencing any numbness or peripheral neuropathy, because then they're at risk of injuring themselves without even really knowing it. They need to inspect their feet daily after exercise. Avoid exercising in the extreme heat or cold. So for someone living in Minnesota, they should be exercising indoors right now, right? Then avoid exercise during periods of poor metabolic control, and then teaching them to stretch or warm up basically 10 to 15 minutes before they start to exercise. Another key item to managing diabetes is monitoring glucose levels and ketones. Monitoring blood glucose levels is the cornerstone of diabetes management. So when you think of your patient experience caring for them in the hospital or a transitional care unit, remember they are going home, right? So they're going to need to learn how to monitor this themselves, and they call it self-monitoring of blood glucose levels. Right? You're not going home with them to check their blood glucose for them. So remember that as you guys are checking your patients. If they are newly diagnosed with diabetes or if they have poor management, you really want to include them. Make sure that they know how to check them themselves and educate and teach them and any family that is going to be involved in their care. Right? So they have found with the research that when they started the self-monitoring of blood glucose, it has dramatically altered diabetes care. Right? So now they are able to tell every day just how their condition is doing. There are so many different diabetes meters out there. Some of them even link results directly to the provider, or to an app on the smartphone, which our younger generations really enjoy because they get to see everything there, they get to track how they're doing, right? So there are so many things out there on that. And then nurses are going to play a key role in teaching their patients how to do the self-monitoring, how often to do it, and then what to do in response to the result. So the next one is continuous glucose monitoring system. And I'll show you a picture of that. But wait, I'm getting ahead of myself. A little more, this is how important self-monitoring is. A little more on that. They do usually recommend diabetics to self-monitor 2 to 4 times a day when they are on insulin. And this is going to be, in general, before meals and then again at bedtime. And then for people who are not using insulin, the recommendation is 2 to 3 times a week. But they need to make sure that they're getting this at various points. So is it a fasting? And then they need to include 1 2-hour postprandial, so 2 hours after eating, reading in there as well. Right, so that gives the provider a bigger picture of just how well their current medication management is working. And then, of course, for anyone who's diabetic, they should be taught to test when they think that they're experiencing hypoglycemia. All right, so back to continuous glucose monitoring system. I have a picture of it on the next slide, but it is a sensor that is placed subcutaneously in the abdomen, and then it's either wireless or connected to a monitor, and then the device can be placed in a pocket, it can be hooked on clothing, so they wear it at all times. Right? They collect data, and the data is downloaded and analyzed after 120 to 168 hours. So one of the keys here, though, is this is not an insulin pump, right? The machine doesn't determine insulin doses, but it will show the prescriber if the treatment is adequate. It's also a really good option for people who aren't very compliant on finger sticks or they're self-monitoring for whatever reason. They don't have the time, they don't like to stick themselves, whatever it is. They can have one of these put on and then it gives them the picture. It's going to be best for someone who has type 1 diabetes. All right, the next one is testing for that glycosylated hemoglobin or the A1C. And again, this is the one that shows the blood sugar over a period of 2 to 3 months. And the reason it can do that is because when blood glucose levels are high, glucose molecules are going to attach to the hemoglobin in red blood cells. The longer the amount of glucose in the blood remains above normal, the more the glucose is going to bind to the hemoglobin, and the higher the glycosylated hemoglobin level becomes. This whole complex, so the hemoglobin attached to the glucose, is permanent for the life of that individual red blood cell, and the life of them is approximately 120 days. So that's why it gives you that 2 to 3 month range. Right, so as I mentioned in patho, this is the test that people can't cheat on. Right? It's going to tell us that big picture between those 2 and 3 months. And then the final thing for monitoring is testing for ketones. And this is going to be done in your type 1 diabetics. Right? Ketones in the urine are going to signal a deficiency of insulin and control. They give them dipsticks. They do it themselves at home, right? They stick the dipstick in the urine and it'll turn purple when ketones are present. So you want to teach them to do this if they have 2 blood glucose readings that are above 240. And then the next slide here is just that picture of the continuous glucose monitoring system. So you can see this one's wireless. Let me show you. All right, so here is where the sensor is placed subcutaneously into the abdomen, and you can see his monitor here in his pocket. So the next step in management of diabetes is drug therapy. Right? So they're either going to use insulin, and as I mentioned in patho, insulin has to be used in type 1 diabetes because they do not make insulin. And then depending on how well controlled type 2 diabetes is, they may or may not use insulin. And then your oral anti-diabetic agents are for type 2. I give you a slide here that talks about the different insulins. Again, we are going to talk so much more about this in pharmacology. But just know that there's different types of insulins. There's a rapid acting, short acting, intermediate acting, very long acting, and then there's an inhaled insulin that's rapid acting. I have actually never seen this prescribed before. So with your rapid acting, it's going to act rapidly, right? It's not just a clever name. There are 3 types of rapid acting insulin. There's your Lispro, your Aspart, and your glucine, right? So your Humalog, your Novolog, and your Apidra. I know a lot of people really know the brand name of insulins, but again, for the purposes of NCLEX, you do want to start learning these generic names instead. Really what you're going to see in practice is going to be the Lispro or the Aspart. Okay. So the reason they're called rapid acting is because they have a faster onset than compared to the other ones. So anywhere between 5 and 15 minutes. And then they only last for a couple hours. Right? So what these are used for is the rapid reduction of glucose levels. So they use it to treat postprandial hyperglycemia or to prevent nocturnal hypoglycemia. Right? So basically, these are the ones you're going to give before a meal and before bedtime. Okay. And then your short acting, same thing. They don't take too long to act, just a little longer though. This is going to be your regular insulin. Takes about 30 to 60 minutes to start working and lasts a little longer, about 4 to 6 hours. Okay, so the reason why it's really important to know how fast they work, especially when talking about your short and rapid acting, is because it's going to determine when you give it. Right? So if someone is eating their dinner at 5 p.m., and you give them their rapid acting at 4 p.m., this starts working in 10 to 15 minutes, right? You might have the patient become hypoglycemic before they even get a meal. So you're really going to want to give these about 15 minutes before to right before they start eating. Whereas your short acting, you can give it 20 to 30 minutes before a meal. So here's another Miami story, warning you now, right? The hospital I worked for in Miami, they, for whatever reason, pharmacy decided they were going to put for the morning AccuCheck or the morning blood glucose check by the nurse, that they were supposed to do it on that overnight shift, right? Overnight shift, you leave at 7 a.m. So they would do the blood sugar level, they draw it around anywhere between 5 and 6:30 in the morning, and then they would cover. Well, our floor, they didn't eat breakfast until 8:30, 9 o'clock. So if they got insulin at 4 in the morning, 5 in the morning, especially rapid acting or even the short acting, by the time we went to give them a meal, you don't understand how many times we would find hypoglycemic patients. It took a lot of explaining and teaching to really get them to understand why they needed to wait and not cover them. So then what happened was they would decide they'd check the blood glucose before the end of their shift, and then the oncoming day shift nurse would give it before they ate. So that brings us to intermediate acting. They act in between, right? So they're going to act longer. This is going to be your NPH. So they start working in about 2 to 4 hours, and then they last anywhere from 16 to 20 hours. I know it says here they're usually taken after food, but usually what I see is that they're just given twice a day, right? So that way it gives you full coverage. A lot of times you'll have a mix, and it'll be like, let's say, Novolog 70-30. So what that's saying is It's got 70% Novolog in it, so 70% of it is rapid acting, and that 30% is the intermediate acting. So there's all sorts of different preparations out there, and that's really beneficial if they have both ordered, so you don't have to stick them twice. Then there's your very long acting, Glargine, Detamir. These are the two common ones. They start to work anywhere from 1 to 6 hours. And it's continuous, right? There's no peak. It gives you 24-hour continuous medication coverage. These are really good for control, right? They don't cause the up and downs that a peak would cause. Usually prescribed at night, but as long as it's the same time every day, it really doesn't matter what time it's prescribed. Right? I know you will see in practice sometimes Lantus being given twice a day. There is really no reason for that though, because again, if you look, it lasts 24 hours and there's no peak. So you're sticking them twice for no reason. I'm not quite sure why prescribers do that. All right, so now we're getting into the nursing plan. So as the nurse, you are going to be the one in charge of monitoring or teaching self-monitoring of your diabetic patient. When they're in the hospital, they usually prefer a blood glucose target of between 140 and 180. This is according to your textbook. I'll tell you that a lot of research has found that the tighter the control, especially in the hospital, the more positive benefits there are. So I know even my awesome, lovely hospital changed to covering anything above 120. So it depends on the provider, what scale they use, but that is that target, is that blood glucose level of 140 to 180. Okay. In the hospital, they do prefer insulin over oral antidiabetics, even for type 2. And the reason behind this is some of those oral antidiabetics interfere with and can cause some kidney failure with certain exam contrasts, and you never know when they might need an exam or a imaging with a contrast. So I know the protocol for my floor was anyone who came in on oral diabetic, specifically metformin, we took them off of it and we put them on a sliding scale. Another reason why it's beneficial is because it gives you that tighter control. Hospitals use insulin protocols or order sets, right? And saying how they should really minimize complexity. They should be able to be easily understood by the staff or the nurses. Nurses need adequate training on it, including standardizing hypoglycemic treatment, and then making guidelines available for goals and insulin dosing. The next slide, let me click on it, is an example, and I just grabbed a random example off of the internet of a sliding scale order. So the physician would go, or whoever the provider is, right? It doesn't have to be a physician. They would go and they'd check whether or not they want finger stick blood glucose, and do they want it before meals or before tube feeding bolus? Do they want it every 6 hours? That one's usually done if they are NPO or nothing by mouth, or if they're on continuous tube feedings. And then it talks about the PRN orders for hypoglycemia, and then when to call the provider, and then they have to pick the sliding scale below. So they can also tweak the order in this case for before bed, or the 2100. And then they pick whether or not they want to use Novolog for the sliding scale or Novolin R. And then there's an example of a sliding scale. I'm sure most of you have seen it in clinical already, but let's say you check your patient's blood sugar before breakfast, and the result is 241. Right, so based on that, you're going to give, depending on if the provider selected very low dose, moderate dose, or their own dose. So let's say they're on a low dose scale. That 241, you're going to give them 6 units. And then most of the time, the insulin order or the sliding scale order comes with the hypoglycemia protocol too. So this one, if the patient is awake, alert, and not in PO, you would follow that 15-gram rule. So you give them the 15 grams of carbohydrate, and they recommend the 4 ounces of juice or 4 ounces of regular soda, 3 graham crackers, 8 ounces of milk, right? So it gives you options. If the blood sugar is less than 60 and the patient is in PO or not alert, right, they can't swallow, you're going to give them the 50% dextrose IV push, and you're going to, of course, want to notify the physician. And then that rule of 15 means you repeat the blood sugar in 15 minutes. If it remains below 80, you're going to repeat. If it goes above 80, you're going to just double check that blood sugar in 1 hour. Right? So the prescriber picks what they want, and then this is what the nurse follows. All right, back to this. Education, I cannot emphasize enough how important education is, which is another reason why it is really important that nurses understand the disease and how to treat it, because how on earth can you educate someone on how to treat their own disease if you don't understand it? Right, so as I touched on, you want to educate on weight loss, exercise, teaching them potential complications. Sometimes scare tactics work great. Right, so I'll give you the story of my ex-husband. When he was diagnosed with diabetes, at first, that initial shock, because both of his parents had it as well, right? That's why I blame him for my daughter having it, not me. Right? No one in my family has diabetes. But anyway, when he was first diagnosed, he's like, I don't want to lose a foot, or all these things that, the common person knows about diabetes. So he was really strict. He lost some weight. He would check his blood sugars the 4 times a day he was recommended. He took his pills every day. And then, of course, that wore off. So he stopped checking his blood sugar. Sometimes he would forget to take his medication. And so I finally told him, I'm like, that one of the complications of not having good controlled diabetes is impotence, right? And of course that freaked him out, and then he began the process all over again. Who knows what he's doing now, right? Not my problem. I don't know. I don't think he's controlling it very well, but you do want to definitely educate, even if it takes scare tactics. Right? Something else you want to educate on is options for weight loss, right? What support they have. There's lots of support groups out there for patients who are diabetic. I think this is really important when they're adolescents. So connecting with other adolescents that are going through the same thing, since, this age group, adults mean nothing. It's all about people in their peer group. And then you could also, again, educate them about the disease process, what to expect, what to monitor for, basically giving them that illness trajectory, right? So remember that 3-legged stool, right? Exercise, diet, medication, right? So you want to definitely give them all of the medication education as well, including when to take it, when not to take it, adverse effects, things to help with that, right? Also really important is teaching them the signs and symptoms of hypoglycemia and hyperglycemia. So with hypoglycemia, you're going to see they're going to be pale. They might have cool, moist skin, anxious, hungry. They could have a headache or fatigue. They might be sweating. They might have altered vision, and then decreased level of consciousness and seizure. With hyperglycemia, they are flushed, dry, warm skin, weak, nausea and vomiting, increased thirst, blurred vision, abdominal pain, confusion, lethargy, decreased level of consciousness. All right. And then that third piece of it is collaborative care, right? Nurses don't work alone. We're not an island. Right, so you want to collaborate with a physician or nurse practitioner. And they might have a lot of different providers. So they might see a family practice or internal medicine, endocrinologist, cardiologist, neurologist, pain specialist. There are all sorts of doctors and providers that someone who has diabetes may see. It's really important that everybody is talking to each other. Everyone's on the same plan. And then there's also the diabetes nurse educator. And then they may have a counselor, psychologist, or psychiatrist, along with a nutritionist. So on this slide is a really great resource. It's out of your book, and it's on a patient education piece. So the basic skills you should be teaching people with diabetes, right? So you want to give them an overview of the patho. And they should have a basic definition of what diabetes is, right? Having a high blood glucose level. They should know normal blood glucose ranges and what their target range is. They should know that the effect of insulin and exercise, right? These are going to decrease glucose. The effect of food and stress, including illness, right? In illness and in stress, glucose goes up. And then basic treatment approaches. As for the treatment modalities, they should understand how to administer insulin or take their oral drugs. They should understand meal planning. And then they should understand definitely how to monitor blood glucose, and for type 1 diabetics, their urine ketones. And then, as I mentioned on the last slide, they need to be able to recognize the symptoms of hypoglycemia and hyperglycemia, how to treat it, and how to prevent complications. And then some other information. They're going to need to know where to buy and store their insulin, right? What about their syringes? How do they dispose of their needles and their sharps? How do they get their glucose monitoring supplies? And then when and how to contact the primary provider. So this slide touches on a very important potential complication of diabetes, and that is the various foot ulcers that might come about. So you definitely want to teach them good foot hygiene and foot care tips. So one of the important things is taking care of their diabetes, right? If they have controlled diabetes, if they're taking their medications and they're keeping their blood glucose levels where they need to be, they are definitely much less likely to experience the complications such as the foot ulcers and the unhealing wounds. They need to inspect their feet every day, right? So one of the complications that comes along with diabetes is your different peripheral neuropathies. So someone who has decreased sensations in their feet might not notice a little tiny sore. And then that little tiny sore can turn into the picture you see before you. And that is why it's really important they check their feet every day. They want to check for changes in temperature, right? So if they have trouble seeing their foot, if they're obese or whatever the reason, back problems, aches, those kind of things, give them a handheld mirror and teach them to see them that way. They need to wash their feet every day. They need to wash them in warm, not hot water. And then dry them well, especially in between the toes. They really shouldn't be soaking their feet, right? Just a quick wash. And then making sure that they check their temperature of the water with either their elbow or a thermometer. Because again, if they have decreased sensation in their feet, they should not be dipping their toes in to check the temperature that way. They need to keep their skin smooth and soft, so a thin lotion. Not between the toes, though. You don't want to develop that the cracking in between the toes. They should smooth corns and calluses very gently using a pumice stone, right? They shouldn't pick at them with scissors or a razor or a knife. They need to wear shoes and socks at all times. Trim their toes when needed. Protect their feet from extreme temperatures. Keep blood flowing, so definitely putting feet up when sitting. Wiggling the toes, right? Keeping them moving Try to avoid sitting cross-legged for a long period of time. No smoking. And then they need to check with their primary provider. And then call them, especially if they have anything they notice. So here you have a list of potential nursing diagnoses that pertain specifically to diabetes. Right? This is a long-term chronic complication. Anytime anything is chronic, you might have the risk of ineffective coping, as well as interrupted family processes, knowledge deficit, actual or risk for disturbed sensory perception because of those neuropathies, risk for ineffective health or self-health management, risk for infection, and risk for unstable glucose. This is not an exhaustive list by any means, though. And it doesn't include the possible diagnoses for the complications that go along with diabetes. So some lifespan considerations, right? Because treatment needs to be tailored as people go through the different lifespan. With children, you're going to want to look at their developmental stage and cognition, right? Obviously, an infant or a preschooler can't really do their own self-management, so you're going to want to include their primary care provider, whether it's mom, dad, or whoever it may be. Right? So when you look at preschoolers, right, they're the ones that really want autonomy, right? They're the no age. So you should allow them maybe to choose their snacks, of course, giving them a couple healthy options, or have them pick which finger gets stuck stuck. We'll stay with that. Okay. School-age children, they're now able to be a lot more involved in their care. They should be taught how to recognize their symptoms of hypo and hyperglycemia. Right? They are old enough where they can carry their rapidly acting sugar, right, their glucose tablet or something, and take it when they need to. Those good old adolescents, right? They could possibly rebel against the regimen, especially if it makes them feel like they're not like their peers, right? So it's really hard to tell an adolescent you should not go and eat pizza at the pizza party because they're not going to want to be the only kid eating the grilled chicken breast, right? Or they may be embarrassed to self-monitor in front of their peers or give insulin or, something like that. So keep that in mind. They really seek to create a separate identity from their parents. So they need an individualized plan. They need to be the target of the plan, right? So they should be speaking to the adolescent as a nurse, not the parent. And then giving them that plan of care while they're at school. Right? And then your elderly. Diagnosis is way more challenging as you age because blood levels increase just by aging, so it could lead to a misdiagnosis. They may not have those classic symptoms of the 3 Ps either. It may just be that they come in with a low blood pressure or periodontal disease, an infection, something like that. And then they also have, they may need a longer healing time, especially because they might have a lot of other comorbid conditions going along with it. And then you definitely want to help with coping. They are going to need, again, support. So finding out who their support system is, and then just teaching them ways to cope with living with the disease. And here's your question for you. So ideally, the goal of diabetes education is to, 1, make all clients responsible for the management of their disease. 2, involve the client's family and significant others in the care of the client. 3, enable the client to become the most active participant in the management of diabetes. Or 4, provide the client with as much information as soon as possible to prevent complications of the disease, the diabetes. And I'll give you a quick hint. Anytime an NCLEX question as something as absolute as all or none, that's never the right answer. So the right answer is 3. You want to enable the client to become the most active participant in the management of diabetes, right? It's not realistic to say that you're going to make all clients responsible, right? What if they're an infant? What if, they have something else going on? All right. So I'm going to leave the lecture off here just because of the amount of time it already is. I do want you to know that I could spend, again, all day talking about diabetes and nursing management. I'm not going to because I don't think anyone wants to hear me speak for 24 hours. I don't want to hear myself speak for 24 hours. So what I recommend is really going through that textbook and looking at the sample care plans. All right, so stay tuned for the lecture on the thyroid component of it.